Thank you. Thank you both for inviting me and giving this talk on stent placements and how to keep them from moving. These are my disclosures, and my talk is not going to be associated with any of these industries or the devices that I'm going to be talking about. They're going to be very generalized. But what I want you to get out of this is basically an overview of the different stent technologies that we have. Obviously, and then the 2 points that were given to me is how should we deploy these things, and then what tactics are there available to keep them from migrating. A little bit on history on stents. Just where did the word come from? Charles Stents was a oral surgeon. He had developed a compound, they call it stent compound. Esser was a plastic surgeon and used that compound to mold things, to keep things in place, and the concept of stenting came about. We know that we have stents for everywhere in the body now, and we're going to talk about GI. And when we talk about all these, most of what I'm going to talk about, and obviously afterwards we can put it into the different questions, but I think the biggest issue is as far as at least the problems of migration, it's the upper stents, because these are the way they're made and the characteristics of them. And I'm going to talk very little about enteral or colonic stents or biliary stents. But obviously, if anything that comes up or questions, I'll be happy to answer. When we're talking about a stent, is what do we want in a stent to make it do what we want it to do? Obviously, the reason for it is an obstruction, so we want it to be smooth on the inside so it doesn't get clogged up. That's some of the early versions of stents would get placed, but then they will clog up, so the patients have no clinical success. For the big thing that we're going to be talking about today is migration, so therefore some sort of rougher or outer anatomy differences, and this either could be a flange or it could be just a rougher or anchorings of some sort so that it doesn't slide away. And some of these are going to be for something that's tight or obstructed, so therefore either the lumens may be different, so therefore you need to know that they come in different sizes, different lumens, and or the pressure that they can exert on a radial can also be different. The pictures that we often draw, these nice straight tubes, but we know that we talk about sleeves, or we talk about some sort of duodenal sweeping. These things are quite complex, and the angulations and the bends also need to be flexible from the stent standpoint so that we don't create a secondary problem. You have to understand the different delivery mechanisms, whether these are going to go over a wire, this is going to go through a scope, whether you use fluoroscopy or not, and we'll touch a bit on that, as well as radiographic identification markers that these things have, either the stent itself or the deployment mechanism, because these are all sort of the guides that will tell you if you're doing a good job or not. When we talk about stents, I just threw a few here, and so that a couple of things that you always want to know is, we mentioned it already, whether it's what kind of mechanism are you going to have. Is this going to go through the working channel of the scope, or is this going to go over a guide wire? And depending on traditionally the enteral or the colonic stents are your traditional through the scope stents, and the more foregut stents are going to be over the guide wire stents. Get some water here. But the other point that I want to make about stents is one significant difference that you find in stents is whether the stent itself elongates or foreshortens once it's deployed. And the foreshortening of the stent, the biggest difference is that if you get a stent that's going to be 8 centimeters or 9 centimeters long, when it's in its catheter system, it may be 12 centimeters long. So you have to gauge for that difference. What's going to happen is foreshortening. There are some other stents that do not foreshorten, and therefore the size of the stent, when you see it in fluoroscopy, when you see it in live, still in its sheath, it's going to deploy and it's going to be exactly the same size. So the pros and cons to each of these, the ones that do not foreshorten, sometimes the problems is that if the lumen does not accommodate them, then the stent will infold onto itself. And those are the things to consider about placing these stents. Where do we put the stents? We put them in malignant, and that's really our FDA approvals for these stents are going to be in malignant situations. But a lot of what we end up dealing in these clinical scenarios is other things like benign strictures or fistulas or leaks. And that's where we also get into higher rates of these complications that we talk about. And again, my main talk is migration. When we talk about how good are these stents, a lot of it is dependent on the pathology of what we're doing it, what we're using it for. And we talk about stents being placed for neoplastic process where there's a tumor involved and the stricture is significant. This is likely not going to change. our results about, number one, clinical success are very high. But the problem that I'm given to discuss is migration also seems to be lower. I will talk a little bit about studies later on about fixation, and some of these numbers bounce all over the place. But where it gets really tricky is when we start talking about more benign diseases, whether it's a stricture and then the stent opens up the stricture, or things that don't have a stricture like our fistula and our leaks. These numbers start to also vary. The clinical success of our stent placements, let's say especially in the bariatric leaks, also seem to be quite different whether we're dealing with something that is early on versus something that's late on. And that's also sort of separated as whether this is a leak or this is a fistula. And we know that the leaks tend to respond quite well if you end up involving them early on by stenting versus someone that they send to you after 12 months and they've been bounced around for a number of places. You're going to have much worse outcomes as far as clinical success. So in order to attack the two complications that I'm going to deal with is the technical failure. So let's teach you how to put these ideally in the right way. And then we'll talk about migration and how to prevent that. So deploying a stent, there's several things to be looking into. We talked already about strictures and plenty on management of strictures. But if I'm going to deploy a stent and I have a stricture and that's what I'm placing it for, the main things that I got to deal with or think about is, am I going to dilate this thing or not? And a lot of it depends on, can I traverse it or not? And we just heard very nicely, basically what the most ideal thing to do is let the stent do its job, so therefore do not dilate this, or only dilate this enough so that you can either traverse it with your scope or traverse it with a deployment device that you're going to use. And the use of guide wires, whether you're going to use fluoroscopy or not, it also depends on your technology. If you have stents that are over a guide wire, you could go ahead and place the guide wire across the stricture or across the leak, and then go ahead and do the rest of the case on the direct visualization with the scope alongside where the stent is going to be deployed. In the scenario where the stent is through the scope, then a lot of times the distal deployment, this could not be visualized. You may want to use fluoroscopy or not based on your guide wires. So this is a case where this is a benign refractory stricture. First thing you do is traverse this thing so that I can safely put a guide wire across. I don't want to just push a guide wire, especially a rigid guide wire. I like using a savory guide wire. So I just push this across. I make sure I traverse this. This is now at the distal stomach, and exchange it. So therefore the guide wire will remain in place and we end up removing the endoscope. Over the guide wire, just as we did a savory sort of dilation, we go ahead and introduce the delivery system of the stent. But I like seeing this under visualization. So I could do this whole thing under fluoroscopy, but instead of bringing in a CM, I just put in the endoscope right at the area where I know I want to deploy this. We deploy it in direct visualization, and we're done. If you want to, you can also use a combination of endoscopy and fluoroscopy and have both. The more challenging, the more limitations, the more your distal landmarks are more of an issue, then fluoroscopy becomes more important. If your only importance is where your proximal landmark is going to be, direct visualization is all you need. And this is the sort of my preferred method in some of the ICU patients. Instead of bringing them into the endoscopy suite where I can then do all the fluoro business, in the ICU I just take my travel cart, deploy the stent, and we don't need to use any fluoro. But of course, in the teaching institution, we're going to always run into issues. The stent goes either too far or too small, or too distal, or too proximal. Here we have a case where we just finished deploying the stent, and we can see the stricture, and we can see that the stent is right at the very, very sort of entrance of this tumor. So obviously it's not where we want it to be. It's not going to do anything there, and if anything, it's just going to migrate in 2 seconds. So endoscopically, just I want to demonstrate to you technique-wise, you can just grab this proximal aspect of the stent and just jimmy it up a little bit, and under direct visualization, again, you can see it's a perfect location. You're happy with it. We're good to go. Obviously, the opposite can also happen. You deployed it. You want to go and take a look at it. It doesn't look like it's sitting right. It looks like it's way too proximal. And when endoscopically you look at it, you realize that the stent is just at the beginning of the tumor, and therefore, no bueno. So again, what we can do here is just go ahead and grab that distal end of the stent. Especially since it's just deployed right now, you can go ahead and proceed. In the scenario where that distal stricture was very, very severely obstructed or occluded, and you felt uncomfortable pushing the stent across, then you could go ahead and throw in a second stent across that area, or go ahead and dilate it a little bit more and proceed in pushing it across. If you have a nice view, something like this, the stent is going to move along very nicely. It's absolutely I would have no problem telling you you're fairly comfortable to just go ahead and grasp it and that distal flange and go ahead and push it in distally. That gives you sort of a nice view that the stent is not going to be, once you can get that biopsy forceps out, shows you that we're distal across that GE junction and into the stomach across this GE junction tumor. Recently we had a post in our Flex Endo Facebook group, the use of these partial coverage stents, and this is going to be a little bit more of my talk about how to minimize these things from preventing. But the issue is, well, once you put these things in there, how in the heck do you go ahead and take them out? If we just grab these stents and just try to yank them out, they're not going to go anywhere. This longitudinal forces, the grasp of all that tissue ingrowth is too significant, so therefore it's not going to go anywhere. So I'm just here demonstrating if you grab it and keep pulling on it, it's not going to be of any great success. So one technique that's been publicized a lot is you can throw in a secondary stent over this, and that stent will cause necrosis of all that tissue, and then therefore you can come on back down the line, usually a few weeks down the line, and that tissue has sort of been ablated or necrosed by pressure, and then you can go ahead and use the biopsy forceps again and just grasp it and remove it. What I like to do is to just go just as lightly distal to that granulation tissue, to one of these open flanges, as you can see the rat tooth go ahead and do right now. But you're going to be grabbing on the side where the granulation tissue is. And now push that stent completely opposite direction. So in the lumen of the esophagus, you're pushing right against in the opposite direction. And that really is the best way to break that granulation tissue. As soon as you do that, now the stent is very mobile and very easy to remove. One other technique is sort of distally grasping these things in some of these stents that have a lot of tissue on the proximal aspect of it. You're not too happy just grabbing it and pulling it forward. I do feel fairly comfortable doing that. This scenario I just demonstrate sometimes, I promise you that these sutures, when you pull them, a few months down the line, they're all going to break. This is a nice view of, you pull on it, it just breaks in half. That same distal flange all the way that we used a little while ago to be able to push the stent into location. It's also a nice way to having a challenging scenario of removing these things. Just go ahead and grab that distal flange and it will completely invert the stent into itself. Just got to grab the biopsy forceps so that it doesn't keep migrating out of the scope. And as soon as you start pulling, you'll see the stent continue to migrate into itself, infolding. So this is the more debatable part is how do we keep these things from moving? And it made me think a lot because I had a particular way of thinking about this. We just were in a course a few months ago. And interesting, I pulled the panel, and a number of panel experts were very much pro securing the stents, and I was very pro just placing in stents that were bigger, longer, wider. And I said, well, I'm glad they gave me this talk so I can take a look and see what's going on. But how do we make these things prevent from migration? Everywhere you read, someone's going to tell you stents and stents migrate. So bigger sizes, longer stents, the covering, whether you use a partly covered or fully covered, are going to have differences. And that's the things that I mainly relied upon. But then more sort of aggressive interventions are clips, glues. I'm not sure too much about that, and I'm not touching on that. If anybody has more information, I'll be happy to hear. But then there are all sorts of suturing techniques, either transnasal suturing techniques or endoscopic suturing techniques. And let's sort of go into some of these things. This is a study that came out from the Cleveland group, Dr. Marks, sort of 200 plus cases predictive as to what's going to happen with these stents. The majority of these were non-fixation, and in their overall population, they saw a 20% migration rate. And the small population where they fixated it, they used a combination of whether clips, sutures, or transnasal sutures. And in this study, there was no significant difference whether they sutured them or not sutured, but they used any sort of fixation device or not. But they also predicted that certain sort of diseases, like especially the benigns is what we would expect, the esophagectomy, the gastric bypass, diabetes, and if you used a covered self-expanding metal stent, were your prognostic factors for having the migration. about feasibility, about that over-the-scope clip, which is very aggressive compared to the through-the-scope clips. Feasibility that if you place these things, it's 100% able to be placed. A very small study demonstrates that they don't migrate, but again, this is more of a selective patient population, which is cancer, and in these, we already know that we have a better result. Here's an interesting study where I always thought that migration within a cancer population would be quite small. This is a study where evaluated almost 100 patients, basically, with fully covered metal stents, whether they secured them or did not use sutures. The majority of them, 67, were no sutures, 26 were sutures. These were for malignant patients. And there was a significant statistical difference of 0.004, 7% versus the 25% migration. Suturing definitely benefited these patients from having these stents remain in place. And no significant complications between the two, although the non-suturing group had a pneumonia and complication from death. I would expect higher complications from putting in suturing devices into the esophagus and trying to suture these things. But how about doing a study where you're using this for benign disease, which is where we end up finding a lot of these problems. And these are fully covered stents, whether they're sutured or unsutured. And here, again, more of what we were expecting to see, whether you suture these fully covered stents for these benign diseases, migrations higher than we saw in the malignancy, but 16 compared to 33% migration for the fully covered in the benign diseases with no sutures placed. Clinical success was also higher, and statistically being that the stent remains in place and therefore resolves the clinical problem. And no significant adverse effects. So one of my concerns of suturing these things is that going to give you higher adverse complications. It does not seem to be the problem. And this is sort of then where it confused me, because this is now evaluating a combination of what I like to do. So this is, let's say we have benign disease and we're going to use fully covered stents and we're going to suture them, but we're going to compare that to using partly covered stents and not suturing them. And a total of 74 patients, 46 were sutured, 28 no sutures. Remember, the sutured were fully covered, the unsutured were partly covered. Clinical success, same in both scenarios. Migration, higher percentage in the sutured group, which looks quite high compared to all the other studies, but there is no statistical significance based on the design of the study. And obviously they commented that the removal of these stents, of the partly covered stents, were more challenging. That's why I like to show that video. So I want to conclude that stents is something that's quite valuable and important to our surgical armamentarium. Being familiarized with the different stents, their sizes, the characteristics, how to use them is quite important. There's a certain trend to continue to do more aggressive techniques in preventing these things from migration. That trend tends to be suturing of the stents. And some of the challenges about suturing endoscopically, I think, will also continue to evolve as we get better and better technology from industry. So thank you very much.